minimally invasive anterior approach to the hip. The minimally invasive anterior approach to the hip is used mainly for elective joint replacement surgery but can also be used for reduction of displaced femoral neck fractures and drainage of hip joint infections. The approach preserves muscle and in expert hands may be associated with faster initial recovery from surgery. Because the approach gives less exposure of the joint, the use of an image intensifier is advised by many to check the level of femoral neck osteotomy as well as the position of the acetabular component. The operation can be performed on a regular radiolucent table. Some surgeons, however, advocate the use of traction during femoral neck osteotomy and acetabular component insertion. Position of patient. Place the patient supine on the operating table, figure 8-2. This supine position permits the use of an image intensifier, which is of great value in determining the position of prosthetic components in joint replacement surgery. Landmarks and incision. The anterior superior iliac spine is subcutaneous and is easily palpable in thin patients. In obese patients, it is covered by adipose tissue and is more difficult to find. To palpate it, bring your thumbs up from beneath the bony protuberance. Palpate the tip of the greater trochanter on the lateral aspect of the thigh. Incision. Mark the tip of the greater trochanter and the anterior superior iliac spine with a skin marker. Make an 8 cm longitudinal incision beginning 1 cm below and 1 cm lateral to the anterior superior iliac spine. Center of 754. The incision should be at the level of the tip of the greater trochanter, figure 8-18. Aim the incision in the direction of the fibular head. Internervous plane. One internervous plane is used between muscle supplied by the femoral nerve and muscle supplied by the superior gluteal nerve. Superficially, this plane lies between the sartorius femoral nerve and the tensor fasciae latae superior gluteal nerve. Deeply, the plane lies between the rectus femoris femoral nerve and the gluteus medius and minimus superior gluteal nerve, figure 8-48. B. Superficial surgical dissection. Divide the fascia covering the tensor fasciae latae at the medial edge of the muscle. Staying within the facial sheath, develop a plane between the sartorius muscle anteromedially and the tensor fasciae latae posterolaterally, figure 8-19. Staying within the facial sheath will reduce the chances of damaging the lateral femoral cutaneous nerve. Deepen this plane by blunt dissection to expose the interval between the rectus femoris and the tensor fasciae latae. The rectus femoris muscle is enclosed in a facial sheath. Incise the anterior portion of the sheath to reveal the muscle and retract it medially. Then carefully incise the posterior aspect of the sheath to reveal the lateral circumflex vessels, which are often large and need ligation. Deep surgical dissection. Develop a plane between the rectus femoris muscle and the gluteus minimus muscle. Palpate the femoral head lying underneath the hip joint capsule. Overlying the capsule is some fat. Gently push this off the surface of the capsule using a swab and a respiratory. Some muscular fibers take origin from the hip joint capsule and run down to be inserted just below the lesser trochanter ilicapsularis. These fibers may need to be detached by sharp dissection to fully expose the hip joint capsule. Place a retractor on the inferior surface of the femoral neck, figure 8-20. The reflected head of the rectus muscle arises from a concavity just above the acetabulum. Develop a plane between the rectus and the hip joint capsule and carefully under direct vision place a retractor into the femoral head through the capsule. Perform an H or L-shaped capsulotomy, excising a portion of the 755 capsule and replace the retractors within the hip joint, figure 8-21. One retractor lies inferior to the femoral neck, one superior to it, and the third is placed over the rim of the acetabulum, ensuring that the tip of the retractor is directly in contact with bone. Divide the femoral neck, checking the position of the osteotomy using an image intensifier, figs 8-22, 8-23, and 8-24. Figure 8-18. Make an 8 cm longitudinal incision beginning 1 cm below and 1 cm lateral to the anterior superior iliac spine. Aim the incision toward the head of the fibula. The center of the incision should be at the level of the tip of the greater trochanter. 756. Figure 8-19. Identify the interval between sartorius and tensor fasciae latae and incise the deep fascia covering the tensor fasciae latae muscle at its medial edge. 757. Figure 8-20. Retract the tensor fasciae latae laterally to expose the rectus muscle covered by a facial layer. 758. Figure 8-21. Incise the facial sheath covering the anterior aspect of the rectus to expose the muscle. 759. Figure 8-22. Retract the rectus muscle medially to expose the fascia covering the posterior aspect of the muscle. Incise this facial sheath longitudinally to reveal the lateral circumflex vessels. 760. Figure 8-23. Ligate the lateral circumflex vessels. Expose the anterior hip joint capsule covered by fatty tissue. Some fibers of psoas the ilicapsularis muscle will need to be separated from the capsule by sharp dissection. Incise the anterior capsule of the hip joint longitudinally. 761. Figure 8-24. Position retractors around the superior and inferior aspects of the femoral neck. Place an anterior retractor over the anterior lip of the acetabulum under direct vision, ensuring that the tip of the retractor is placed directly onto bone without any soft tissue intervention. And nerves. The lateral femoral cutaneous nerve. Lateral cutaneous nerve of the thigh reaches the thigh by passing over, behind, or through, usually over, the sartorius muscle, about 2 centimeters below the anterior superior iliac spine. 3 or more branches may exist whose course is very variable. The nerve must be preserved when you incise the fascia over the medial edge of the tensor fasciae latae. Cutting it may lead to the formation of a painful neuroma and may produce an area of diminished sensation on the lateral aspect of the thigh, figure 8-410. See figure 8-5. Staying within the facial sheath of the tensor fasciae lati will protect the nerve from 762 damage. The femoral nerve lies almost directly anterior to the hip joint itself, within the femoral triangle. Because the nerve is well medial to the rectus femoris, it is not really in danger unless you stray far out of plane to the wrong side of the sartorius and the rectus femoris. If you lose the correct plane during deep dissection, locate the femoral pulse by palpation. Within the femoral triangle, the artery lies medial to the nerve figs, 8 to 15 and 816 vessels. The ascending branch of the lateral femoral circumflex artery crosses the operative field, running proximally in the internervous plane between the tensor fasciae lati and the rectus femoris. It lies posterior to the posterior part of the facial sheath that encloses the rectus femoris muscle. Ligate or coagulated when you separate the two muscle C figs, 8 to 8, 815, 8 to 16, and 8 to 17. How to enlarge the approach. This approach is a minimally invasive one. If you start to struggle and lose the surgical plane, the approach can always be converted to the classic anterior approach. It is better to create more muscle damage than injure a vital structure or insert a prosthesis in an incorrect position. Be aware, however, that this approach can be extended distally if required by splitting vastus lateralis, see figure 8-13. Anterior lateral approach to the hip. The anterior lateral approach is the approach most commonly used for total joint replacements. It combines an excellent exposure of the acetabulum with safety during reaming of the femoral shaft. Popularized by Watson Jones D. Hirsch, Personal Communication, 1981, and modified by Charnley, Harris, Hardinge, and Mueller. 6. It exploits the intermuscular plane between the tensor fasciae lati and the gluteus medius. It also involves partial or complete detachment of some or all of the abductor mechanisms so that the hip can be adducted during reaming of the femoral shaft and so that the acetabulum can be more fully exposed, figure 8-25. The abductor mechanism can be released either by a trochanteric osteotomy or by detaching part of the anterior part of the gluteus medius. 763. And the whole gluteus minimus from the trochanter. 6. The two methods seem to offer different approaches, but they are actually variations on a theme. The differences should not obscure the fundamental fact that all anterior lateral approaches exploit the same intermuscular plane between the tensor fasciae lati and the gluteus medius. Uses of the anterior lateral approach include the following. 1. Total hip replacement 6.7. Dry. Hemiarthroplasty. TRZY. Open reduction and internal fixation of femoral neck fractures 22. 4. Synovial biopsy of the hip. 5. Biopsy of the femoral neck. Position of the patient. Place the patient supine on the operating table, so close to the edge that the buttock of the affected side hangs over figure 8-26. Tilt the table away from you as the patient lies flat. Both maneuvers allow the buttock skin and fat to fall posteriorly, away from the operative plane, and lift the skin incision clear of the table, making it easier to drape the patient. You must take the table tilt into account when you insert the acetabular portion of a total joint replacement because the guides used to position the acetabular prosthesis usually take the ground as their reference plane. Drape the patient so that the limb can be moved freely during surgery. Landmarks and incision. Landmarks. The anterior superior iliac spine is subcutaneous. It is easy to palpate in all but the most obese patients who have a thick layer of adipose tissue covering it. To palpate it, bring your thumbs up from beneath the bony protuberance. The greater trochanter is a large mass of bone that projects up and back from the junction of the shaft of the femur and its neck, figure 8-27. The shaft of the femur can be felt as a resistance through the massive vastus lateralis on the lateral side of the thigh, see figure 8-49. 764, figure 8-25. The route of the anterior lateral approach to the hip joint. Figure 8-26. Position of the patient on the operating table for the anterior lateral approach to the hip. Bring the greater trochanter to the edge of the table and allow the buttocks, skin, and fat to fall posteriorly, away from the operative plane. 765, figure 8-27. Incision for the anterior lateral approach to the hip. Vastus lateralis ridge, a rough line that marks the fusion site of the greater trochanter to the lateral surface of the shaft of the femur, is easiest to palpate from distal to proximal. It is not palpable in obese patients. Incision. Flex the leg about 30 degrees and adduct it so that it is lying across the opposite knee, both to bring the trochanter into greater relief and to move the tensor fasciae lati anteriorly. Make an 8 to 15 cm straight longitudinal incision centered on the tip of the greater trochanter. The length of the incision relates to the size and obesity of the patient as well as the surgeon's experience. The incision crosses the posterior third of the trochanter before running down the shaft of the femur, see figure 8-27, internervous plane. There is no true internervous plane for this approach. Since the gluteus medius and the tensor fasciae lati have a common nerve supply, the superior gluteal nerve. However, the superior gluteal nerve enters the tensor fasciae lati very close to its origin at the iliac crest. Therefore, the nerve remains intact as long as the plane between the gluteus medius and the tensor fasciae lati is not developed up to the origins of both muscles from the ilium, see figure 8-25. 766. Superficial surgical dissection. Incise the fat in the line of the skin incision to reach the deep fascia of the thigh. Using a sponge, gently push back subcutaneous fat off the fascia lata until you can reach the fascia at the posterior margin of the greater trochanter. Incise the fascia lata at this point, entering the bursa that underlies at figure 8-28. Now, divide the fascia lata in the line of its fiber superiorly, heading proximally and anteriorly in the direction of the anterior superior iliac spine. Finally, complete the facial incision by extending the cut distally and slightly anteriorly to expose the underlying vastus lateralis muscle. Elevate this flap anteriorly by getting your assistant to retract it forward, using a tissue, holding forceps. Now, detach the few fibers of gluteus medius that arise from the deep surface of this facial flap and locate the interval between the tensor fasciae lati, which is being lifted anteriorly by the assistant, and the gluteus medius. This is best done by blunt dissection using your fingers. A series of vessels cross the interval between the tensor fasciae lati and the gluteus medius. These act as a guide to the interval, but require ligation figure 8-29. Next, place a right-angled retractor deep to the gluteus medius and minimus, and retract these muscles proximally and laterally away from the superior margin of the joint capsule that covers the femoral neck figure 830. 767, figure 8-28 incise the fascia lata posterior to the tensor fasciae lati. Retract the fascia lata and the tensor fasciae lati. 768, envelopes, anteriorly, revealing the gluteus medius and a series of vessels that cross the interval between the tensor fasciae lati and the gluteus medius. Figure 8-30 retract the gluteus medius posteriorly and the tensor fasciae lati anteriorly, uncovering the fatty layer directly over the joint capsule. Fully externally rotate the hip to put the capsule on stretch. Identify the origin of the vastus lateralis at the vastus lateralis ridge. Above it is the anterior aspect of the joint capsule, at the junction of the femoral neck and shaft. Bluntly dissect up the anterior part of the joint capsule, lifting off the fat pad that covers it. The fat pad can reduce postoperative scarring and adhesions and should be preserved even though it intrudes into the operative field. Figure 8-31. The safest technique is to use a swab. Deep surgical dissection. Deep surgical dissection consists in detaching part or all of the abductor mechanism and then dissecting up the femoral neck superficial to the capsule of the joint until a suitable retractor can be placed over the anterior lip of the acetabulum. Two techniques improve exposure of the acetabulum by neutralizing the abductor mechanism, allowing the femur to fall posteriorly. They also permit adduction of the leg for safe femoral reaming and accurate. 769. Positioning of prosthetic stems within the femoral shaft. The technique chosen depends on the prosthesis to be used. 1. Trochanteric osteotomy. Performing a trochanteric osteotomy allows complete mobilization of the gluteus medius and minimus muscles, which in turn allows excellent exposure of the shaft of the femur during femoral reaming. Palpate the vastus lateralis ridge on the lateral border of the femur, from distal to proximal. Osteotomize the trochanter using either an oscillating saw or a jiggly saw, and reflect it upward with the attached gluteus medius and minimus muscles. The base of the osteotomy should be at the base of the vastus lateralis ridge. The upper end of the osteotomy may be either intracapsular or extracapsular. The thickness of the osteotomized portion of bone varies considerably, depending on the prosthesis you intend to use. Alternatively, detach the trochanter using two cuts at right angles to one another. This will leave the trochanter looking like the roof of a Swiss chalet. This technique maximizes the bone-to-bone contact surface area and, because of its shape, also is inherently more stable after fixation than a straight osteotomy. Deflect the osteotomized trochanter upward. To free it completely, release some soft tissues including the tendon of the piriformis muscle from its posterior aspect. Figs 8-32 and 8-33. 2. Partial detachment of the abductor mechanism. Place a stay suture in the anterior portion of the gluteus medius just above its insertion into the greater trochanter. Cut the insertion of this anterior portion off the trochanter. Identify the thick white tendon of the gluteus minimus as it inserts under the anterior aspect of the trochanter and incise it. The exact amount of the gluteus medius that must be detached varies considerably from case to case. Figure 8-34. In thin, non-muscular people, you may even be able to preserve the whole of the gluteus medius attachment. 770. Figure 8-31. Bluntly dissect the fat pad off the anterior portion of the joint capsule to expose it and the rectus femoris tendon. 771. Figure 8-32. Osteotomize the greater trochanter. 772. Figure 8-33. Reflect the osteotomized portion of the trochanter superiorly with the attached gluteus medius to reveal the joint capsule. 773. Figure 8-34. The joint capsule may also be exposed by partial resection of the gluteus medius tendon from the anterior portion of the trochanter. 774. Figure 8-35. Reflect the head of the rectus femoris from the interior portion of the joint capsule. Bluntly dissect up the anterior surface of the hip joint capsule in line with the femoral neck and head. Attach the reflected head of the rectus femoris from the joint capsule to expose the anterior rim of the acetabulum. Figure 8-35 and inset. This plane is easier to open up if the leg is partly flexed, since the rectus femoris remains relaxed. Flexing the leg also keeps the femoral nerves and vessels off the stretch and farther from the operative field. Elevate part of the psoas tendon from the capsule. Because both the rectus femoris and the psoas may insert into the capsule, the plane between muscle and capsule is often difficult to establish. Place a Holman retractor on the anterior rim of the acetabulum. Make certain that the dissection and the insertion of retractors remain beneath the rectus femoris and iliopsoas, because the neurovascular bundle lies anterior to the psoas. If you cannot develop a plane between the psoas and the capsule, incise the capsule and insert a retractor around the femoral head so that you can see the joint better. Incise the anterior capsule of the hip joint with a longitudinal incision. Develop this into a T-shaped incision by cutting the attachment of the 775 capsule to the acetabulum as far around as you can reach. Now incise the capsule transversely at the base of the neck to convert the T-shaped incision into an H-shaped one, figure 8-36, and insert. Dislocate the hip by externally rotating it after you have performed an adequate capsulotomy, figure 8-37. Nerves. The femoral nerve is the most laterally placed structure in the neurovascular bundle in the femoral triangle, thus the structure closest to the operative field and most at risk. The most common problem is compression neuropraxia, caused by overexuberant medial retraction of the anterior covering structures of the hip joint. Less frequently, the nerve is directly injured by retractors placed in the substance of the iliopsoas. See figs 8-47 and 8-48. Vessels. The femoral artery and vein may be damaged by incorrectly placed acetabular retractors that penetrate the iliopsoas, piercing the vessels as they lie on the surface of the muscle. You can avoid this complication by making sure that the tip of the retractor is placed firmly on bone, with no intervening tissue. The anterior retractor should be placed in the 1 o'clock position for the right hip and in the 11 o'clock position for the left hip. Finding the correct plane between the rectus femoris and the anterior part of the hip joint capsule is easier if the limb is in about 30 degrees of flexion. Alternatively, avoid placing any retractors over the acetabular lip until after a capsulotomy has been performed and the femoral head excised, when the exact position of the acetabular margin is obvious and retractors can be inserted under direct vision. 776. Figure 8-36. Incise the anterior joint capsule to reveal the femoral head and neck and the acetabular rim. If further proximal exposure is needed, incise the fascia lata proximally toward the iliac crest and along the iliac crest anteriorly. To facilitate dislocation of the hip, incise the tight fascia lata and the fibers of the gluteus maximus insert. The profunda femoris artery lies on the psoas muscle, deep to the femoral artery. The artery may branch off from the femoral artery just distal to the inguinal ligament, and this anatomical variant lies very close to the anterior lip of the acetabulum. The artery may be damaged by poorly placed retractors. Be aware that damage to either of these arteries may not be obvious at the time of surgery because any bleeding that may occur may be into the retroperitoneal space and not into the surgical wound. Fractures of the